Here we are going to talk about the transport of respiratory gases by blood and how gases move through our bloodstream and other components that are moving through our bloodstream as well. So let's begin by talking about oxygen transport. Molecular oxygen is carried in the blood by two main ways. About 1.5% of molecular oxygen is dissolved in our plasma, and the remaining 98.5% is loosely bound to each iron of hemoglobin in our red blood cells. So as you can see on the picture on the far left-hand side of the screen, there are oxygen molecules bound to this glob of hemoglobin. So each hemoglobin molecule is composed of 4 polypeptide chains, and each has an iron-containing heme group. So each hemoglobin can transport up to 4 oxygen molecules. And when the hemoglobin molecule has 4 oxygen molecules attached to it, it is said to be fully saturated. When it has anything less than 4 molecules attached to it, it is either partially saturated or unsaturated. Oxyhemoglobin is the hemoglobin-oxygen combination, and reduced hemoglobin or deoxyhemoglobin is hemoglobin that has released oxygen. So the loading and unloading of oxygen is facilitated by a change in the shape of the hemoglobin molecule. As oxygen binds, the hemoglobin molecule will change shape and increases its affinity for oxygen. As oxygen is released, the hemoglobin molecule also can change shape again and cause a decrease in affinity for oxygen. So the rate of unloading and loading of oxygen is regulated to ensure that adequate oxygen is delivered to our cells. And there are many factors that influence the hemoglobin saturation. So on the far right-hand side of this screen, you can see what is called the oxygen hemoglobin dissociation curve. So this curve will tell you the entities that will cause the curve to shift to the left, thereby increasing the affinity for oxygen, and the entities that will shift the curve to the right when there is a decreased affinity for oxygen. So for example, a left shift could be caused by a decrease in the partial pressure of carbon dioxide, a decrease in the presence of hydrogen ions, a decrease in temperature. And what could cause a right shift would be an increase in the partial pressure of carbon dioxide, an increase in the hydrogen ions, which would result in a decrease in pH, an increase in 2,3-DPG, as well as an increase in temperature. So as you can see, what makes the curve shift to the left is opposite from the factors that make the curve shift to the right. So the partial pressure of oxygen heavily influences the binding and release of oxygen with hemoglobin. And this graph here is the percent of hemoglobin saturation that is plotted against the partial pressure of oxygen concentrations. The partial pressure of oxygen has a great influence on hemoglobin saturation rates. In our arterial blood, the partial pressure of oxygen is 100 millimeters of mercury and contains 20 milliliters of oxygen per 100 milliliters of blood. So this is a 20% volume. Here, hemoglobin is said to be 98% saturated. So any further increases in the partial pressure of oxygen, such as deep breathing, will only produce minimal increases in oxygen binding. However, our venous blood content is much different. The partial pressure of oxygen is 40 millimeters of mercury. And here, hemoglobin is still fairly saturated. It's about 75% saturated. But in our venous blood, we have what's called the venous reserve. And this oxygen it is the oxygen remaining in the venous blood that can still be used. So this figure here focuses on the amount of oxygen carried by hemoglobin and shows you how the amount that's carried depends on the partial pressure of oxygen, the amount of oxygen that's locally available. And this relationship ensures optimal oxygen pickup and delivery. Here we're going to talk a little more about 2,3-DPG and the Bohr effect. So 2,3-DPG or 2,3-diphosphoglycerate is produced by our red blood cells during glycolysis. And the 2,3-DPG levels rise when oxygen levels are low. As our cells metabolize glucose, they use oxygen, which results in increases in the partial pressure of carbon dioxide, as well as increases in the presence of hydrogen ions in the capillary blood. So as hydrogen ion presence increases in the capillary blood, this causes a decline in the blood pH levels, resulting in a condition known as acidosis. And the increase in partial pressure of carbon dioxide causes the hemoglobin-oxygen bond to weaken. This is known as the Bohr effect. And what results as the Bohr effect is oxygen unloading occurs where it's needed most. Heat production in active tissue directly and indirectly decreases hemoglobin's affinity for oxygen, and this allows increased oxygen unloading to active tissues. Hypoxia is an inadequate oxygen delivery to our tissues, and this can result in a condition which you see on your screen here known as cyanosis. And cyanosis causes a bluish discoloration of the skin. Hypoxia is based on its cause, and there are several different types of hypoxia. Anemic hypoxia has several different causes. Anemic hypoxia can be caused by too few red blood cells, having abnormal red blood cells, as well as having too little hemoglobin present. Ischemic hypoxia can result from an impairment in our circulation or when our circulation becomes blocked. In histotoxic hypoxia, our cells are unable to use oxygen because we have some type of metabolic poison present in our body. In hypoxemic hypoxia, this is caused by some type of abnormal ventilation or a pulmonary disease. And carbon monoxide poisoning can also cause hypoxia, especially carbon monoxide poisoning from fire. Hemoglobin has a 200 times greater affinity for carbon monoxide than it does for oxygen. Carbon dioxide is transported in our blood in three forms. Approximately 7 to 10% of it is dissolved in our plasma. 20% of it is bound to the globin part of hemoglobin, and this is referred to as carbaminohemoglobin. And the remaining 70% is transported as bicarbonate ions. The formation of bicarbonate ions involves carbon dioxide combining with water to form carbonic acid, which quickly dissociates into bicarbonate and hydrogen ions. And you can see this represented here in the chemical formula in the top portion of your screen. So carbon dioxide transport occurs primarily in our red blood cells, where the enzyme carbonic anhydrase reversibly and rapidly catalyzes this reaction. So when I ask you what the catalyst of this reaction is, please note that I'm looking for the enzyme carbonic anhydrase, and this will be a test question. In our systemic capillaries, after bicarbonate is created, it quickly diffuses from the red blood cells into our plasma. And the outrush of bicarbonate from the red blood cells is balanced as chloride moves into our red blood cells from the plasma, and this is referred to as the chloride shift. In our pulmonary capillaries, the process occurs in reverse. So bicarbonate moves into our red blood cells while chloride moves out of the red blood cells and back into the plasma. The bicarbonate binds with hydrogen to form carbonic acid. The carbonic acid is split by carbonic anhydrase into carbon dioxide and water, and carbon dioxide then can diffuse into the alveoli. I do want you to know what the Haldane effect is, and the amount of carbon dioxide transported is affected by the partial pressure of oxygen. So the lower the partial pressure of oxygen and hemoglobin oxygen saturation, the more carbon dioxide can be carried in the blood. So the reduced hemoglobin buffers hydrogen and forms carbaminohemoglobin more easily. And this is known as the Haldane effect. And this whole process encourages carbon dioxide exchange at our tissues and at our lungs. At our tissues, as more carbon dioxide enters the blood, more oxygen dissociates from the hemoglobin. Remember, this is known as the Bohr effect. And then as deoxyhemoglobin releases oxygen, it more readily forms bonds with carbon dioxide to form carbaminohemoglobin. And there's a really important buffer system that I want you all to know about. This is known as the carbonic acid bicarbonate buffer system. And this system is really important because it helps blood resist changes in pH. So if the hydrogen concentration in our blood rises, excess hydrogen will be removed by combining with bicarbonate to form carbonic acid, which will then dissociate easily into carbon dioxide and water. If the hydrogen concentration begins to drop, the carbonic acid will dissociate and release the hydrogen ions. Bicarbonate is considered the alkaline reserve of the carbonic acid bicarbonate buffer system. And as we undergo changes in our respiratory rate and the depth of respiration, these changes can affect our blood pH. So slow, shallow breathing causes an increase in carbon dioxide in our blood, and that results in a drop in pH. So the pH of our blood becomes more acidic. And when we undergo rapid deep breathing, this causes a decrease in carbon dioxide in our blood, and this results in a rise in our pH in our blood, so our blood becomes more alkaline. And changes in ventilation can help adjust our pH when there are disturbances caused by different metabolic factors. And breathing plays a major role in the acid-base balance of our body. So our brain is responsible for controlling our respiration. And respiratory rhythms are regulated by higher brain centers, chemoreceptors, and other reflexes. And there are many different types of neural controls which involve different types of neurons in the reticular formation of the medulla and the pons that help us to breathe. In the medullary respiratory centers, there are clusters of neurons in two areas of the medulla that are the most important for you all to know. And they are the ventral respiratory group and the dorsal respiratory group. And we're going to begin by talking about the ventral respiratory group, or the VRG. And this is the group that is responsible for the rhythm generation, and it is known as the integrative center. The VRG consists of networks of neurons in our brainstem that extend from the spinal cord to the pons medulla junction. And it sets what's called eupnea. Eupnea is the normal respiratory rate and rhythm, which is approximately 12 to 15 breaths per minute. The VRG's inspiratory neurons excite the inspiratory muscles via the phrenic and the intercostal nerves. The phrenic nerves innervate the diaphragm, and the intercostal nerves innervate the external intercostals. And the expiratory neurons inhibit the inspiratory neurons, and they work in an antagonistic fashion. In the dorsal respiratory group, or the DRG, there are networks of neurons that are located near the roots of cranial nerve 9. And this group integrates input from the peripheral stretch and chemoreceptors, and then sends information to the VRG neurons. Not much is known about this group of neurons, but just know that the DRG is important for integrating the peripheral sensory input and modifying the rhythms that are generated by the VRG. And we also have what are called pontine respiratory centers, and the neurons in this center influence and modify the activity of the VRG directly. They act to smooth out the transition between inspiration and expiration, and vice versa. And they transmit impulses to the VRG that modify and fine-tune breathing rhythms during vocalization, sleep, as well as exercise. And lesions in this area of the brain can lead to what is called apneustic breathing, where the patient takes prolonged inspirations. The origin of the breathing rhythm is not yet fully understood. There's still a lot of research that needs to be done to fully understand breathing as an entire mechanism. One hypothesis is that we have pacemaker neurons in the VRG that control rhythm intrinsically. And this is the most widely accepted hypothesis. So there's reciprocal inhibition of two sets of interconnected pacemaker neurons in the medulla that are responsible for generating rhythm. And each neuron set controls the other to ensure that rhythms are generated properly. So there are many different factors that influence our breathing rate and the depths of our breath. So depth is determined by how actively the respiratory center stimulates the respiratory muscles. So the greater the stimulation, the greater the number of motor units that will be excited, and this will increase the depth of inspiration. So the rate is determined by how long the center is active, and both the rate and the depth are modified by our changing body demands. And our respiratory centers can be affected by numerous factors, including chemical factors, the influence our higher brain centers exert on it, pulmonary irritant reflexes, as well as the inflation reflex. And I know that was a lot of information, but don't worry, we're going to dive into each one of the aforementioned entities a little more in depth. So let's begin by talking about the chemical factors. The chemical factors are the most important of all the factors that affect the depth and the rate of inspiration. If there's any type of change to the levels of the partial pressure of carbon dioxide or the partial pressure of oxygen and the pH, this can really alter the breathing rate and depth. Changes in these levels are sensed by the central chemoreceptors as well as the peripheral chemoreceptors. The central chemoreceptors are located throughout the brainstem, while the peripheral chemoreceptors are found in the aortic arch as well as the carotid arteries. So the partial pressure of carbon dioxide has a really strong influence on how our breathing rate and depth occur. If the partial pressure of carbon dioxide in our blood rises, this can result in a condition called hypercapnia. And what happens here is the carbon dioxide is going to accumulate in our brain, and then this will join with water to become carbonic acid. As carbonic acid dissociates, hydrogen ions will be released, and this causes a drop in our pH and increases acidity in our body. The increased hydrogen ions stimulate the central chemoreceptors of the brainstem, which synapse directly with the respiratory regulatory centers. And the respiratory centers increase the depth and the rate of the breathing, which act to lower the partial pressure of carbon dioxide in our blood. And then this will cause the pH levels to rise back to normal levels. If the partial pressure of carbon dioxide in the blood decreases, respiration will become slow and shallow, and a condition known as apnea may result. So apnea is a breathing cessation that may occur when the partial pressure of carbon dioxide drops abnormally low. So swimmers sometimes voluntarily will hyperventilate to enable them to hold their breath longer. And what hyperventilation does is this causes a drop in the partial pressure of carbon dioxide, which causes a delay in respiration, and this delay in respiration allows the partial pressure of carbon dioxide to have the necessity to be built back up. However, you have to be really careful when you're hyperventilating because this can cause dangerous dropping levels of the partial pressure of oxygen. Hyperventilation is caused when there's an increased depth and rate of breathing that exceeds the body's need to remove carbon dioxide. And this may be caused by anxiety attacks. And hyperventilation leads to decreased carbon dioxide levels in the blood, which can result in hypocapnia. And this can cause cerebral vasoconstriction as well as cerebral ischemia, which may result in dizziness and can lead to fainting. Early symptoms include tingling and involuntary muscle spasms in the hands and face. So the treatment for hyperventilation is to breathe into a paper bag because this increases the carbon dioxide levels that are being inspired and restores the carbon dioxide levels back to homeostatic levels in the body. Chemical factors directly influence the partial pressure of carbon dioxide. Peripheral chemoreceptors, which can be found in the aortic arch as well as in the carotid bodies, sense arterial oxygen levels. And when there's a declining partial pressure of oxygen, this normally only has a slight effect on ventilation because there's a huge reservoir of oxygen bound to hemoglobin. So for a substantial response to occur, there needs to be a substantial drop in arterial partial pressures of oxygen. So the arterial partial pressure of oxygen needs to drop below 60 millimeters of mercury to stimulate increased ventilation. When the chemoreceptors are excited, they cause the respiratory centers to increase ventilation. The arterial pH can also modify the respiratory rate and rhythm even if carbon dioxide and oxygen levels are normal. And this is mediated by the peripheral chemoreceptors. So a decreased pH may reflect carbon dioxide retention, accumulation of lactic acid, or excess ketone bodies that may be present. And the respiratory system controls attempt to raise the pH by increasing the respiratory rate and the depth. So let's summarize this a little bit. The rising carbon dioxide levels are the most powerful respiratory stimulant. Normally, the partial pressure of oxygen in the blood affects breathing only indirectly by influencing the peripheral chemoreceptor sensitivity to changes in the partial pressure of carbon dioxide. When the arterial partial pressure of oxygen falls below 60 millimeters of mercury, it becomes the major stimulus for respiration via the peripheral chemoreceptors. And any changes in arterial pH resulting from carbon dioxide retention or metabolic factors act indirectly through the peripheral chemoreceptors. So now we're going to shift gears a little bit and talk about the influence of the higher brain centers. And we're going to talk about the hypothalamic controls. So the hypothalamic controls act through the limbic system to modify the rate and the depth of respiration. The hypothalamus controls the 4 F's: feeding, fleeing, fighting, and sex. So if there's any type of alteration, such as you holding your breath because you're angry or you're gasping with pain, the hypothalamic controls are going to signal to the body that the rate and depth of respiration need to be modified. We also have what are called cortical controls, and the cortical controls direct the signals from the cerebral motor cortex that bypass the medullary controls. For example, voluntary breath holding, at least until the brainstem reinstates breathing when blood carbon dioxide becomes critical, is modulated by the cortical control system. Now let's talk about pulmonary irritant reflexes. So the receptors in the bronchioles respond to irritants such as dust, accumulated mucus, or noxious fumes. The receptors communicate with the respiratory centers via the vagal nerve afferents. And they promote reflexive constriction of air passages. And the same irritant that triggers a cough in the trachea or the bronchi, or a sneeze in the nasal cavity, that can cause a pulmonary irritant reflex to occur. And finally, we'll talk about the inflation reflex. The inflation reflex is also known as the Herring-Brewer reflex. And what happens here is stretch receptors in the pleura and airways are stimulated by lung inflation. And there are inhibitory signals that are sent to the medullary respiratory centers to end inhalation and allow for expiration to occur. And this may act as a protective response more than a normal regulatory mechanism. During exercise, adjustments need to be made to regulate both the intensity and duration of our respiratory system and the processes that the respiratory system is carrying out. So if these adjustments are not made, then there are many different pathological conditions that can result. So let's talk about hyperpnea. Hyperpnea is an increased ventilation in response to metabolic needs. And ventilation can increase 10 to 20-fold depending on the metabolic demand. So during exercise, ventilation will increase abruptly, increase gradually, and then finally reach a steady state. And when exercise stops, there's a small, abrupt decline in ventilation followed by a gradual decrease. And surprisingly, the partial pressure of carbon dioxide, the partial pressure of oxygen, as well as the pH remain constant during exercise. So any abrupt increase in ventilation that occurs as exercise begins involves 3 neural factors. The first being any type of psychological stimuli. If the person is anticipating the exercise, that could cause an increase in ventilation as the different parts of the brain are stimulated and they send communication signals to different areas of the brain which house the respiratory centers, resulting in an increase in ventilation. The second being simultaneous cortical motor activation of the skeletal muscles and respiratory centers. And the third being excited impulses being sent to the respiratory centers from proprioceptors in moving muscles, tendons, and joints. So ventilation declines suddenly as exercise ends, as I mentioned, and this is because the three neural factors get shut off. And there's a gradual decline to the baseline, which is due to the decline in carbon dioxide flow after the exercise ends. Exercise leads to anaerobic respiration and the formation of lactic acid. The lack of oxygen in our muscles is not from poor respiratory function, but rather from insufficient cardiac output or skeletal muscle inability to increase our oxygen uptake. When we travel to high altitudes, our brain automatically signals to the respiratory system that changes need to be made. So any quick travel to altitudes above 2,400 meters, which is approximately 8,000 feet, may trigger symptoms of acute mountain sickness. So the atmospheric pressure and the levels of the partial pressure of oxygen are lower at high elevations. And if you travel too high too quickly, you may experience headaches, shortness of breath, nausea, and dizziness. And in severe cases, lethal cerebral and pulmonary edema can occur. Instead of traveling rapidly, you should acclimate yourself to the high altitude. And acclimatization is when the respiratory and hematopoietic adjustments are made with long-term moves to high altitude. So what happens when our respiratory system adjusts to high altitude properly, the chemoreceptors can become more responsive to the partial pressures of carbon dioxide when the partial pressures of oxygen decline. And if there's a substantial decline in the partial pressure of oxygen, this will directly stimulate the peripheral chemoreceptors to respond. And this response will result in an increase in minute ventilation that will stabilize in a few days, and this will actually cause our respiratory system to increase our minute ventilation to 2 to 3 liters per minute higher than what it would be at sea level. And high altitude conditions always result in lower than normal hemoglobin saturation levels due to the availability of less oxygen. A decline in blood oxygen stimulates the kidneys to accelerate the production of erythropoietin. And our red blood cell numbers are going to increase slowly to provide long-term compensation. Now we're going to talk about some lung diseases, and we're going to begin by talking about the chronic obstructive pulmonary diseases, also known as COPD. And COPD is exemplified by chronic emphysema and chronic bronchitis. And the key feature that these two diseases share is there is an irreversible decrease in the ability to force air out of the lungs. Some other common features that both of these diseases share is that most of the patients who develop these diseases have a history of smoking. And the patients may present with dyspnea, which is labored breathing. Patients also may be coughing constantly and may have frequent pulmonary infections. Most patients also develop hypoventilation accompanied by respiratory acidosis as well as hypoxemia. So let's dive a little bit deeper into emphysema now. So what happens in emphysema is there's a permanent enlargement of the alveoli and destruction of the alveolar walls that results in a decreased lung elasticity with 3 main consequences. The accessory muscles are damaged, and as you can remember, the accessory muscles are necessary for breathing, so if they're damaged, this is going to cause the patient to become exhausted from normal breathing, as they're going to have to use 10 to 15% more energy to breathe at a normal respiration rate. The air that gets trapped inside causes hyperinflation, and this flattens the diaphragm and causes the expanded barrel chest shape that you see in emphysema patients. And both the hyperinflation and the flattening of the diaphragm, which results in the barrel chest shape, reduces ventilation efficiency. And third, the damaged pulmonary capillaries lead to an enlarged right ventricle of the heart. And this can cause heart complications, which could ultimately lead to death. There are also hereditary factors that are involved in emphysema. For instance, some patients have alpha-1 antitrypsin deficiency, which renders them more susceptible to developing emphysema. Now let's talk about chronic bronchitis. Chronic bronchitis is caused when the patient inhales irritants that cause chronic excessive mucus. And what happens is the mucosa of the lower respiratory passages become inflamed and fibrose. And this results in obstructive airways that impair lung ventilation and gas exchange. And the patients will present with frequent pulmonary infections. And as I mentioned with emphysema, one of the main risk factors for developing chronic bronchitis is smoking, as the amount of carcinogens in a cigarette is just downright ridiculous. So now let's move into some of the COPD symptoms and what treatments are out there. So the strength of the patient's innate respiratory drive is the reason behind the different symptoms that are seen. So the people with emphysema are known as the pink puffers. The patient is usually thin because they burn large amounts of energy breathing. They have near normal blood gases, and so their skin is, the color of their skin is pretty normal, and it's not cyanotic. Where on the opposite spectrum, the people with bronchitis are known as the blue bloaters. So the patient is usually stocky, and cyanosis is due to hypoxia, so the skin will appear blue. There are several treatments out there, however, there are no cures for emphysema or chronic bronchitis as of yet. So the treatments include bronchodilators, corticosteroids, oxygen, and sometimes lung volume reduction surgery. Asthma sometimes gets classified as COPD, but asthmatic episodes are acute, not chronic, and there are periods where the patient is symptom-free. Asthma is characterized by coughing, dyspnea, wheezing, and chest tightness, and active inflammation of the airways precedes the bronchospasms that the patient may experience. Airway inflammation is an immune response caused by the release of interleukins, the production of the immunoglobulin IgE, and the recruitment of inflammatory cells. The asthmatic patient will have airways that are thickened with inflammatory exudate that may magnify the effect of bronchospasms. And as you can see in the picture here, many of the patients use an inhaler to administer corticosteroids to relieve their asthmatic symptoms. Tuberculosis, or TB, is an infectious disease caused by the bacterium Mycobacterium tuberculosis. And symptoms of TB include fever, night sweats, weight loss, an intense cough, and the patient may even cough up blood. The treatment is a 12-month course of antibiotics. Unfortunately, there are antibiotic-resistant strains of tuberculosis that have been seen, including multi-drug resistant strains. So pharmaceutical companies are working tirelessly to combat the multi-drug resistant strains and come up with new antibiotics to treat these specific types of strains. Lung cancer is the leading cause of cancer deaths in North America, and 90% of cases are the result of smoking cigarettes. The three most common types of lung cancer are adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. Approximately 40% of the cases are adenocarcinoma, and adenocarcinoma originates in the peripheral lung areas and develops from the bronchial glands and alveolar cells. Between 20 and 40% of the cases are squamous cell carcinomas, and they arise in the bronchial epithelium. And then the remaining 20% of the cases fall under the classification of small cell carcinoma. And these carcinomas contain lymphocyte-like cells that originate in the primary bronchi and subsequently metastasize. Although there's not a cure for lung cancer, there are several new therapies that are on the horizon. However, the most important treatment is early detection. Early detection is key to survival. If the metastases has not yet occurred, surgery may be able to remove the diseased lung tissue and save the patient. If metastases has occurred, there are radiation and chemotherapy treatments that have proven to cause the cancer to go into remission. However, not all cases are curable. But the medical field is making many great steps forward in the treatment of lung cancer. Now let's briefly talk about some embryonic development aspects of the respiratory system. So the upper respiratory structures will develop first. The olfactory placodes invaginate into the olfactory pits, which form the nasal cavities, and these are present by week 4. The laryngotracheal bud is present by week 5. The mucosa of bronchi and lung alveoli are present by the 8th week. And by the 28th week, the premature baby can actually breathe on its own. Throughout the fetal life, the lungs are filled with fluid and blood bypasses the lungs, and the gas exchange takes place via the placenta. When the baby is born, the respiratory centers are activated, the alveoli inflate, and the lungs begin to function. It takes 2 weeks after birth before the lungs are fully inflated. And respiratory rate is highest in the newborns. It's approximately 40 to 80 breaths per minute, and it slows until adulthood, when the breath rate is approximately 12 to 16 breaths per minute. The lungs continue to mature and more alveoli are formed until young adulthood. And as pretty much everything declines with old age, respiratory efficiency decreases with old age as well. Cystic fibrosis is the most common lethal genetic disease in North America. And what happens is there's an accumulation of abnormal viscous mucus that clogs the passageways, which can lead to recurrent bacterial infections. And this affects the lungs, the pancreatic ducts, as well as the reproductive ducts. And cystic fibrosis is caused by an abnormal gene for the chloride membrane channel protein, cystic fibrosis transmembrane conductance regulator, more simply known as CFTR. So the abnormal CFTR protein gets stuck in the endoplasmic reticulum, so it never reaches the cell membrane to carry out chloride transport function properly. So there are treatments out there for cystic fibrosis, however, and very unfortunately, there currently is no cure. Treatments include mucus-dissolving drugs and manipulations to loosen the mucus, as well as antibiotics to stop the recurrent bacterial infections. The patients also may inhale hypertonic saline to thin out the mucus accumulations that are present throughout their body. And there's a lot of ongoing research to try to find a cure for cystic fibrosis. And some of the research involves introducing normal CFTR genes into the respiratory tract mucosa cells. There's research avenues also prodding different proteins to take over the chloride channel protein duties. And other research avenues are aimed at freeing the patient's abnormal CFTR protein from the endoplasmic reticulum.